Let's look at this competency number 28.5. This is define and classify the glomerular diseases. So, we have to classify the glomerular diseases first, and then we have to describe the etiology, pathogenesis, pathology and clinical manifestations of glomerulonephritis. Students, somehow the NMC has missed out the nephrotic syndrome. Okay. So, when we classify the glomerular diseases, we will classify them into two types, nephrotic and nephritic. Somehow NMC has taken glomerulonephritis but missed out nephrotic syndrome. So, we will be taking both of them together under this competency so that you understand them in a better way. Okay. So, let us describe and classify the glomerular diseases. So, whenever we describe the glomerular diseases, okay, we describe them under two headings, okay, nephrotic syndrome and nephritic syndrome. Okay. So, whenever we are talking about nephrotic syndrome, everybody should remember that in nephrotic, okay, the patients with the nephrotic syndrome typically presents with some syndrome complex. That is, they have albuminuria. Okay. That is, albumin is losing in the urine. Okay. Because of this, these patients have hypoproteinemia. So, instead of albuminuria, we can write proteinuria because other proteins can also be secreted. Okay. So, we will write proteinuria. Okay. So, proteinuria and hypoproteinemia and hypoproteinemia. So, because of proteins coming out in the urine, these patients can present with hypoproteinemia. Also, because proteins are leaking, apart from that lipids are also coming in the urine. So, this is lipiduria. But liver compensates for the lipid secretion and our body presents with hyperlipidemia. Okay. So, remember, whenever I am talking about the syndrome complex of nephrotic, although this nephrotic syndrome complex, you will be studying it in detail in pediatrics, and it has been taken as a biochemistry competency. But for now, this is a massive proteinuria. More than 3 gram is lost in a day. Because of this, the protein levels in the body goes very low. So, the osmotic pressure, oncotic pressure of the body goes low and the patient presents with edema. Apart from that, lipid also is secreted. So, lipiduria occurs and there is compensatory liver starts secreting more lipoproteins producing lipidemia, hyperlipidemia. So, once we are clear with these features, remember, whenever I am talking about most common cause of nephrotic syndrome in a child. So, most common cause of nephrotic syndrome in a child is minimal change disease. Most common cause of nephrotic syndrome in an adult is focal segmental glomerulosclerosis. And most common cause of nephrotic syndrome in elderly is membranous nephropathy. Membranous nephropathy. So, they present with the syndrome complex of proteinuria, hyperproteinemia, lipiduria and hyperlipidemia. Okay. So, in child, if this is occurring, think of minimal change. In adult, it is FSGS. In elderly, it is membranous usually. Of course, their morphological features are different in each of them. Similarly, when I am talking about nephritic syndrome, they again present with different syndrome complex. So, this you can remember it as HOHA. Okay. So, HO, H for hypertension, H for hypertension, O for oliguria, H for hematuria and A for azotemia, A for azotemia. So, these patients present with hypertension, oliguria, azotemia and hematuria. Also, you should always remember, whenever I am talking about this syndrome complex, this is typical of acute glomerulonephritis. Again, age is the defining factor. Okay. So, the age is, whenever we are talking about India, so most common cause of glomerulonephritis in India is post-streptococcal glomerulonephritis, which is also called as post-infective glomerulonephritis. That's the most common cause of glomerulonephritis in India. If I am talking about world, most common cause of glomerulonephritis in the world is IgA nephropathy, which we will discuss it as a separate competency later. Whereas, if I am talking about, end stage or rapidly progressive glomerulonephritis, then your answer should be RPGN. So, very bad prognostic, very rapidly progressive glomerulonephritis. So, that is called glomerulonephritis, which you all have to remember. So, these are 3 cases of the glomerulonephritis: post-streptococcal, IgA nephropathy, and rapidly progressive glomerulonephritis. Now, what are the diseases which manifest with both nephrotic and nephritic complexes? You have to remember that combination of these two are seen in a disease called MPGN. This is called membranoproliferative glomerulonephritis. So, membranoproliferative glomerulonephritis usually presents with the complex of nephrotic and nephritic together. Okay, so it presents with nephrotic and nephrotic-like manifestations together. So, that's what you have to remember. So, this is how we classify the glomerular diseases. Now, to understand the urine finding in both of them, okay, so you have to understand the urine finding here itself. So, whenever I am talking about nephritic syndrome, okay, so the urine finding of nephritic syndrome patients will always have dysmorphic RBCs. So, why there are dysmorphic RBCs? Crenated or with echinocytes like this, these kind of RBCs will be there. This basically indicates that there has been a glomerular injury, and that is why the RBCs have become crenated or dysmorphic. Whereas in nephrotic syndrome, when I am looking at the urine finding, we will see lot of oval fat bodies, and resorption droplets are basically seen in the tubules, but they can come out in the urine also. So, what are these oval fat bodies? Because of lipiduria, these proximal convoluted tubule cells have resorbed a lot of lipids. So, when their life is over, they are shed in the urine, they will contain a lot of fat. So, these are called oval fat bodies, and if you see these oval fat bodies under polarizing microscopy, they give you a very characteristic pattern. This is called as Maltese cross birefringence. So, if you look at these oval fat bodies under polarizing microscopy, you will see Maltese cross appearance. So, this is the urine finding of nephrotic and nephritic. Urine finding itself can differentiate both of them. So, if you see dysmorphic RBCs, that's very characteristic of glomerulonephritis. If you see oval fat bodies, which on polarizing microscopy shows Maltese cross appearance, that's very characteristic of nephrotic. And what are the diseases which manifest as nephrotic? In children, it is minimal change. In adult, it is FSGS. In elderly, it is membranous. Whereas in glomerulonephritis, somebody is causing. In India, it is PSGN. In world, is it IgA nephropathy. And in the rapidly progressing is RPGN. Combination of both is MPGN. You have to remember like that. Okay. So, that's how we classify the glomerular disorders. And we will see the urinary findings just now. Okay. So, look at this. Can you see these bodies here, these rounded bodies? They are actually oval fat bodies. And of course, this is under polarizing microscopy. You can see some, this 1, 2, 3, 4. These are what is called as Maltese cross appearance. So, this is Maltese cross appearance and oval fat bodies, which you can see in the urine finding of this patient. Okay. Now, once we are clear with this, that was a picture of nephrotic syndrome. Whereas when it is glomerulonephritis, you can see these aberrant dysmorphic, disshaped RBCs. This dysmorphic RBCs are very, very characteristic of glomerulonephritis. They are very characteristic of glomerulonephritis. Okay. So, that's what we have to know very, very clearly. Okay. So, we have a feature of glomerulonephritis and nephrotic syndrome, which we have to understand. It's very, very clear that you have to understand the urine findings of both of them. Now, once we are clear with it, now we are going to study the glomerulonephritis. We've studied 3 important causes of the glomerulonephritis. Most common in India is PSGN, in world is IgA nephropathy, and end stage is RPGN. Coming to the first glomerulonephritis, that is PSGN. Okay. So, whenever we study any kidney disease, remember, first thing that you're going to ask yourself is this an immune complex mediated disease or not? So, the answer to this question is yes, it is an immune complex mediated disease. Once you know that it is an immune complex mediated disease, the next question you're going to ask yourself, what is the antigen? So, remember, post-streptococcal glomerulonephritis is caused by group A beta hemolytic streptococcus. Okay, group A beta hemolytic streptococci. But obviously, this bacteria, group A beta hemolytic streptococci, is a bacteria. Which part of this bacteria is an antigen? So the antigen here is called as streptococcal pyrogenic exotoxin B. Okay, so streptococcal pyrogenic exotoxin B. This is the antigen which is implicated. So now once this antigen comes into the body, this antigen, our body is going to make antibodies against it. Okay, so this is the antigen and our body is going to make antibodies against it. And this is the antigen antibody complex. This is the antigen antibody complex. So what happens is, somehow whenever I am talking about the kidney, we have studied the basic structure of kidney, isn't it? So I hope you remember, this is the capillary, let's say. This is the endothelium of the capillary, and on the outer side we have podocytes sitting with their foot process. So once this immune complex is formed, okay, this antigen antibody complex goes and deposits initially in this location. This location is a very crucial location. This is called subendothelial location. I hope you understand, guys, whenever we talk about subendothelial location, it's a very dangerous location. Why? Subendothelial location is a very dangerous location. You know why? Because whenever an immune complex is deposited in the subendothelial location, this is an area where it is in close proximity to the blood inflammatory cells, because there are a lot of WBCs flowing in the blood. So it's very close to them. So it's like a, it's like a militant hiding in a military base. So obviously all the WBCs will quickly identify the inflammatory cells. WBCs can go anywhere to pick up the pathogen. So here it is just below the endothelium, it's quickly going to come and eat it up. So these all WBCs are going to come and eat up the inflammatory pathogenic bacteria, obviously. So they know that the immune complex is made up by the bacteria, so let's eat it. So now bacteria also senses some trouble, but who is the cell who is going to respond first to bacteria? Neutrophils. So all the neutrophils from the body are going to rush into the kidney, and whole of this vessel will be stuffed with neutrophils. This is what is called as endocapillary proliferation. That is, inside the capillary there is proliferation of neutrophils. So there are lots and lots of neutrophils filling the capillary. This is what is called as endocapillary proliferation. Once we know endocapillary proliferation is going on, what is going to happen is, now these neutrophils are going to eat up the bacteria. But bacteria also sense the damage. Now they jump from subendothelium to subepithelium space. And there is a saying, isn't it? So after every fear, there is a victory. So when these immune complexes jump from subendothelium to subepithelium space, they are no more immune complexes now. They become humps now. They become subepithelial humps, big subepithelial humps now. So that's called subepithelial humps. That's what they become in the subepithelial space now. So is everybody clear with this now? Okay, so what happens is, the immune complex initially are formed in the subendothelial location, and later on they jump to the subepithelial space to form subepithelial humps. Let's see this. So from subendothelium, these immune complexes move to the subepithelial space, and when they move to subepithelial space, they become very big humps. Okay, so this is called subepithelial humps. Okay, so they become subepithelial humps. Okay, so that is very, very important. So initial part of the deposits are in the subendothelium, and later on they become subepithelial humps. That's the classical feature seen in BSTN. Okay, now once you have seen the pathology, and all of you now know that all the blood vessel is filled up with these blue colored cells. These blue colored cells are nothing but they are neutrophils. Okay, here they are filled with these cells. Okay, so this proliferation is called as, what is this proliferation called as? This is called as endocapillary proliferation. So remember everybody, so whenever we are looking at this, the diagnosis of any kidney disease is always made under three headings. You have to remember this: light microscopy, electron microscopy, and immunofluorescence. Okay, so these are three mandatory techniques which are required. So that means whenever we take a kidney biopsy, okay, so we divide it into three parts. The first part, we put it in 10% buffered neutral formalin. buffered neutral formalin, which is the fixative for light microscopy. The second part we put it in the glutaraldehyde, which is a fixative for electron microscopy. And the third part we put it in Michel's media, which is a fixative for immunofluorescence. Now, what do you see in this? So, look at the glomerulus now, and this is the capillary. So, if you see that this is a very hypercellular glomeruli, okay. Why hypercellular glomeruli? Because everywhere there are neutrophils. Even inside the capillaries, if you look at them, there are neutrophils inside the capillaries. Even inside the capillaries, there are neutrophils. So, this is what is called endocapillary proliferation. So, there is lot of endocapillary proliferation going on. So, hypercellular glomeruli with endocapillary proliferation going on. Now, once you see this, okay, so that's a hypercellular glomeruli with lot of endocapillary proliferation going on, that's seen in light microscope. Now, when we see it on electron microscopy, if you're seeing it in the initial part of the disease, you're going to see subendothelial deposits. But in the later part of the disease, you're going to see subepithelial humps. So, majority of the time you catch the patient in this phase only when you see subepithelial humps. Now, Michel's media, basically immunofluorescence, tells you the composition of the immune complexes. So, whenever it is an immune complex mediated disease, if you tag them with FITC, okay, so you tag them with FITC. FITC is a fluorescent stain, okay, fluorescent stain which is a green color, okay. So, this is fluorescein isothiocyanate, okay. So, what is the name of this? This is called as fluorescein isothiocyanate, okay, fluorescein isothiocyanate. And whenever you put it with the immunofluorescence in FITC stain, you will see that it will show you a lot of granular immunofluorescence, that is, it is an immune complex, so it is deposited like this. This is what is called as a granular immunofluorescence. And if you look at the composition, that what are these immunoglobulins made up of, it is made up of, IgG, IgA, everything is there, IgM, C1, C2, C3, somehow no C4 is not there. So, which complement is not deposited in the hair? C4 complement is not deposited here. Also, you should remember, because all the complements are deposited in the kidney itself, so the patient will present with hypocomplementemia. Because the complements are deposited here, the patient will present with hypocomplementemia, okay. But which complement is not decreased? C4 is not decreased. Also remember, now you think there are so many neutrophils there already to eat immune complex. Will they stay in the vessel, or they will also jump and eat the immune complex? So, they will also jump and eat the immune complex. So, therefore, always remember the phenomena here is that after a point of time when the immune complex is finished, destroyed by the inflammatory cells, complement levels also become normal. So, this hypocomplementemia which occurs in PSGN is always a transient hypocomplementemia. That's a very, very important point that I want you all to remember. So, this hypocomplementemia which occurs in PSGN is a very transient hypocomplementemia and it's not persistent. It will correct by itself in some time. So, remember, whenever we are talking about the pathological finding of PSGN, on the light microscopy, you have a very hypercellular glomeruli. You can't even see the capillaries in between, okay. And on electron microscopy, you will see subepithelial deposits, especially subepithelial humps. Humps means big deposits on the subepithelial sites. On Michel's media, you will see granular immunofluorescence, and all the complements will be deposited. Somehow, C4 is not deposited, okay. Now, let's see what we have read. So, look at this normal glomeruli, everybody. So, this is a normal glomeruli. We start always from outside to inside. So, here you can see lot of parietal epithelial cells. Everybody, you can see all these vessels here. These are normal vessels here. The thickness of the vessel should be as if you have drawn one line with the pencil. And in between the intercapillary space, there is a pink color matrix here called mesangial matrix, okay. And this space should be well patent space, okay. So, this space is a Bowman space that should be patently seen here. On the outer side, these cells here are podocytes which can be seen on the outer side. So that's the normal glomerulus which we have to see. Okay. Also, look at this glomerulus now. What do you see here? The first point that you see here is that the glomerulus has become very hypercellular. You can't see any capillaries here. Okay. So the glomerulus is very hypercellular here. The capillaries are also filled up by something. So if you make a hyper, you will see that there's some cells inside the capillaries also. So every capillary has some lobed cells. So if you highlight here, so let's draw this cell here like this. Okay. So there's these kind of cells filling the capillaries. So the capillaries are not patent. They have some cells here. Here also you can see that all the glomerulus is filled. There is no patent capillaries there. There are a lot of cells here and there. So this is a very hypercellular glomeruli with no patent capillary. This is very characteristic of PSGN. Okay, so it's a hypercellular glomeruli, shows a lot of endocapillary proliferation. Okay, now if you look on the electron microscope, so if you look at the basic electron microscopy first to understand how does the basic electron microscopy looks at. So look at this electron microscopy here. Whenever you look at this electron microscopy, so this dark color material which you can see in the center is your RBCs, which you can see in the center. These are your RBCs. So let's look at the normal electron microscopy. So you all know that this dark structure in the center is the red blood cells. Okay, and inside there are there's some endothelial cells which can be flattened. On the outer side you can see these projections of the cells here like this. Okay, projections of the cell here. So these all cells are podocytes. Okay, so all these cells are podocytes which you should be able to identify. So nothing should come in between them. Now here what do you see here? Here you are seeing again there is this basement membrane here. Okay, there is a basement membrane. Inside there is the endothelial cells here. Okay, and outside again there are podocytes which are pushed to the periphery because there is a big hump here. There's a big hump which is deposited here. So this big hump which is deposited between the basement membrane and the podocyte is a subepithelial hump. Okay, so there was a blood here which is not seen here. Okay, so this is the capillary lumen which comes here. Okay, definitely inside it's lined with the endothelial cells, outside it is by podocytes, and there's a big hump which is present here. This is called subepithelial humps, which is very characteristically seen in PSGN. If you look on the electron microscopy, there will be granular immunofluorescence which can be seen. Okay, so look at this. If you look at this, there will be granular immunofluorescence which will be seen, and if you see them, that this is a very bumpy, big granular bumps which can be seen. So these immune complexes, they are containing all the types of antibodies. So this is a very bumpy immunofluorescence, and this is also called as starry sky immunofluorescence or garland pattern of immunofluorescence. Imagine a garland which you make of flowers. Look at this. How is it looking? It's looking like somebody is making a garland around the kidney. So it's a very bumpy kind of immunofluorescence, showing you a garland pattern or a starry sky pattern of immunofluorescence. That's very characteristically seen in PSGN. And PSGN typically shows you a granular immunofluorescence. And strangely, C4 is not deposited here. So that's the immunofluorescence. So again, in the light microscopy you have seen. So on the light microscopy, all of you remember it's a hypercellular glomeruli with lots of cellularity, capillary spaces cannot be seen. On electron microscopy, there is subepithelial humps, and on immunofluorescence, you have seen a granular pattern of immunofluorescence with garland pattern. So these three features should be very clear in making a diagnosis of PSGN. Now, you know, PSGN is an infective disease. So obviously our inflammatory cells are going to eventually eat up the immune complex, and the 95% of the time the person will become okay. But in very few percent of cases, 5% of the cases, what can happen? Not even 5, okay, it can vary. Now it is even less in today's time because of good invent of antibiotics. Very few percent of the cases, when these immune complexes are jumping from subendothelium to subepithelial side, they can cause damage to the basement membrane. And as you have read in your 28.1 competency, whenever there is damage to the basement membrane, that is going to cause leakage of the fibrinogen into Bowman's space. And who sits there? The Lord Shiva of the kidney, that is the parietal cells. And he's going to get very angry, and he's going to destroy the glomerulus. He's going to form the crescent. So therefore, few percentage of PSGN patients can progress to RPGN, and you should be very careful about this, okay? So remember that always, okay? So PSGN normally has a very good prognosis. It has a transient hypercomplementemia. Patients cure themselves very soon, but in some group of patients, they can progress into RPGN. Also, if you remember the clinical features of the patient, remember PSGN is a type 3 hypersensitivity reaction. So bacteria comes from outside, it forms antigen-antibody complex is formed, it goes and deposits in the kidney and then it causes damage. So formation, deposition and damage are 3 stages in which this disease is occurring. So immune complex forms, immune complex deposits, immune complex damages. So these 3 stages takes at least 10 days to occur. So therefore, type 3 hypersensitivity reaction occurs in 3 steps: formation, deposition and damage of the organ, and it takes approximately about 10 days for the disease to manifest. So that is why PSGN is a type 3 hypersensitivity. So initially a patient has a typical history of infection of upper respiratory tract or lower respiratory tract, and after approximately 10 to 12 days the patient starts presenting with hematuria, oliguria, hypertension and azotemia. That's typical type 3 hypersensitivity reaction which occurs here. So that's the typical course of PSGN, the clinical features and the prognosis and the pathological finding which we have started. So I hope everybody is clear with these points. Etiology, group A beta hemolytic streptococci. Mechanism, pathogenesis, it's a type 3 hypersensitivity reaction. Okay, light microscopy, hypercellular glomeruli with endocapillary proliferation. Okay, electron microscopy, subepithelial humps. Immunofluorescence, granular bumpy deposits. Okay, C4 is not there and it is transient hypercomplementemia. Okay, and prognosis excellent. Okay, so this is what you have to know about PSGN. Is everybody clear with this? Yes.